Hello and welcome to Paincast, Conversations on Pain and Physiotherapy. This podcast is brought to you by the Pain Science Division of the Canadian Physiotherapy Association. I'm Tiffany, a physiotherapist in Toronto, the host of Paincast, and an executive member of the Pain Science Division. This episode is a student-led episode. I mentor physiotherapy students in the Pain Science Division Student Committee, taking them through the process of developing episodes on a topic of their interest. I will let Jules and Brooklyn take over from here.
I'm Jules, a physiotherapy student from the University of Alberta.
And I am Brooklyn, a physiotherapy student from McMaster University.
How should we shift our thinking in terms of acute versus chronic pain? And how will this impact our approach to patients with chronic pain? What is acceptance and commitment therapy, and why is it a good strategy for individuals with chronic pain? We had the pleasure to discuss these questions with Dr. Bronwyn Thompson.
Before we start, as a reminder, Paincast brings together researchers, clinicians, students, and patients to facilitate discussions, knowledge translation, and critical thinking on topics about pain and physiotherapy. The views expressed in each episode are of individual guests. They do not constitute medical advice and do not represent the views of the Pain Science Division nor the Canadian Physiotherapy Association. Enjoy the episode.
Welcome, Bronnie, Dr. Thompson. Thank you so much for being here today. We are so excited to have you on and hear your insights into chronic pain. How are you doing today?
Very good, thank you. It is summer in New Zealand. I'm in Christchurch, New Zealand. That is the river that is closest to me. That's the Waimakariri River. And I live about 5-minute walk to the beach. So very close to the beach. And although it's summer, it's still cold. Not as cold as Canada. Never as cold as Canada.
What is the temperature like there then? How does it compare?
Today, outside, it would be about 22 degrees Celsius.
Okay, it's like minus 30 where I am, so.
And I've been to Edmonton, and Edmonton's got the most gigantic skies, but I can understand how cold it would be.
The sun and the blue skies is definitely a benefit to being in Edmonton for sure. But I'm jealous of you living close to the beach, that's for sure.
I couldn't be as far away from the water as Edmonton. Being by the water in New Zealand is sort of a thing. None of us are very far away.
So I guess along that topic, can you tell us a little bit about who you are and what you do? It sounds like maybe New Zealand is near and dear to you, and maybe what a typical week looks like for you.
My current work is I'm the academic lead for our postgraduate programs in pain and pain management at the University of Otago. My clinical background is occupational therapy and psychology, and my PhD was looking at people we don't see very often. That's people who live well with pain, because I was really interested in around about 30% of people who have pain, but it doesn't seem to be interfering. And I wanted to understand that. That grew out of seeing my partner who lives with ankylosing spondylitis. But at the time that I met him, he was having quite, profound pain, high levels of inflammatory markers, really sore. But he was working full time, and he was a high country firefighter. So he spent a lot of his time carrying heavy things up hills, up mountains, and fighting fires in his spare time. I wanted to understand that. So that's why I investigated what I investigated, because that was in contrast to my clinical work, which has been with people who have persistent pain and they're asking for help for it.
Right.
At a typical week, pretty much I work 3.5 days for the University of Otago in this position. And my so-called spare time, I pretty much geek out about pain, and I make silver jewellery, and I garden, and I have a dog who likes lots of entertainment. I like kayaking and walking and fishing and, reading really trashy novels. Got to admit that, put that out there.
Well, you sound like a very, very cool person, and I love the contrast that you created between the two types of pain topics that you're most interested in. The one being from your partner, someone that's living well with pain, someone that has a chronic condition, and they're still able to work their job at their full capacity and live well. And then the other side of things where you have the patients that are in their chronic pain and it's affecting them a significant amount of more. I'm very curious to dive into that and see just what your insights are into what the difference might be in terms of how people can live well with pain. I mean, we kind of touched on why you're passionate about researching and educating chronic pain management, but do you have anything to add on that?
Suppose I was interested in pain because it is complicated. We don't have simple answers. There's not a lot of certainty in the area. So that means we can never know it all. And there's always something more to learn. That's kept me entertained, curious, and fascinated throughout my clinical career. And I've been working in the field for over 35 years, coming up 40 years now. So this has been my practice area. I'm really interested in how we have these contrasting beliefs about pain, where on the one hand, people are expected to tough it out and we do things like have tattoos, we run marathons. In New Zealand, we play rugby. It's a bit prone to injury and that's absolutely fine. But then people have a pain problem and all of a sudden we want to do what we can to get rid of it. How come? That's really weird. And I wanted to understand this distinction between when people are living well and people are not living well. I thought I'd find out that people who are living well had a whole bunch of strategies that we were teaching people who have chronic pain. I thought those would match up. They don't. That was humbling because why is it? What can we learn from people who live well? And how can we put that into practice to help the people who aren't living so well? And that continues to drive me.
Yeah, so it sounds like you came to the discovery that the way that we have been treating and working with people with chronic pain is not exactly the way that we should be.
Well, it's different lenses. There are certainly good things about the way that I was trained in pain management and the things that we've learned that aren't so good. We've learned a lot in the last 40 odd years, but the things that we do for pain self-management, which is the bit that I'm most interested in, perhaps haven't filtered through to everyday clinical practice nearly as much. And after listening to story after story after story from people who've had trouble with their pain, I think we can do better. That's what keeps me committed to getting information out and translate it into practice.
So to really start this conversation about this paradigm shift and how we can think about chronic pain, can you just begin with a little bit of a definition for our listeners about what chronic pain is versus acute pain?
It would be nice to have a nice simple distinction between the two, and probably it's not there. So we used to think that there was a point at which people tipped over from acute pain into chronic pain. I don't know that we can use timeframes as a very good approach because is it duration? Because people can have an inflammatory problem like ankylosing spondylitis that goes on for life. People can have something like complex regional pain syndrome, and within the first couple of weeks, we can say, oh, I think this is going pear-shaped. So duration might not be the best way of framing that difference. But back in the day, it was the distinction between things that are associated with inflammation, things where we can reduce the pain, we target the tissues, we can do something to get rid of the pain. And chronic pain, we didn't have very effective strategies and we were helping people adapt and cope. So when I talk about that, thinking in the 80s, really. Things have changed a little bit since then. We have a little bit more to offer some people with pain that hangs around a lot, but we haven't got a lot, let's be honest. And I'm not sure that that distinction between it's tissue damage or it's ongoing chronic is a very helpful one, because perhaps it's more about the mechanisms that might be involved, the type of pain. So inflammatory pain, probably we've got some stuff we can do to tackle that, even autoimmune, long-standing chronic diseases. We've got some things that are helpful, but we're less good at managing neuropathic pain and nociplastic pain. And those ones are the ones that tend to be our problem children, ones we don't have as much to help with. So people who have pain that hangs around probably will have pains that fall into that group of neuropathic and nociplastic ones. If you have a neuropathic pain, you can have that acutely. You can compress an ulnar nerve and away you go, you've got neuropathic pain. The distinction is what we do about it and whether we need to do something early that's different from what we do in the long term. I think we need to do all the things all the time, but that's because I think pain isn't something that we need to only treat as a symptom. I think it's an experience. But there's loads of academic discourse about how do we think about this thing, this experience that we've all had, and how do we define it? How do we decide what we do about it? How do we know somebody's got it? And we haven't quite got to the definitive answer. That's why I like working in the area. It's really interesting.
Absolutely. We're going to talk a little bit later about the psychosocial aspect and the overall concept of living well. But you introduced inflammatory pain and neuropathic pain, nociplastic pain. Would you be able to give a little bit of a definition of what those are for the listeners, just in case they're not familiar?
Yep. I can actually divide these pain mechanisms up into four. The first one is nociceptive. So nociceptive is there's activity that activates a nociceptor. So nociceptors are these high threshold peripheral nerves that respond to mechanical, thermal, or chemical stimulation. And we don't have to have injury to have pain that's associated with nociception. Just sit for a while and don't move. You'll have pain. Or bite into a chili pepper. You're not injuring yourself. There's no inflammation. You've got chili pepper and my goodness, it gets your tongue going. You've got pain, right? So that's one lot. The cool thing about nociceptive pain like that is that once we take away that stimulus, you don't have pain anymore. Brilliant. It's awesome stuff. So that's one lot. Then we have pain that's associated with inflammation. This could be tissue damage. This could be an autoimmune thing going on. And that's where we have this inflammatory soup, a whole bunch of substances that are there to basically increase the responsiveness of a nociceptor. So it reduces the amount of information that's needed to trigger it off. And rest of those things in the soup are there to basically settle tissues down, take away the dead stuff, do the trick for healing. Those are really cool. So we've got some stuff we can do about that. The cool thing is when you reduce inflammation, we don't have pain. My partner's a really good example of this. He had really high pain with his ankle and his CRP was very, very high. And when he went on to the adalimumab, which is a biological, his C-reactive protein went down to normal. He had no pain within 2 weeks. He's a poster child for how awesome it can be. So when we successfully treat inflammation, pain tends to disappear. That's really cool. Then we have neuropathic. Neuropathic pain is where there's an identifiable lesion or disease in the somatosensory nervous system. It could be in the periphery, squashed a nerve. We've got some problems with the receptivity, or it could be in the spinal cord injury, tumour, or it could be in the cortex, in the somatosensory parts of the cortex, like post-stroke pain. In those cases, we identify it by listening to the history, finding out the bits that seem to correspond with wherever that nerve distribution might be. Does it look like it's in the right spot? And then we confirm it by doing further investigations. Quite often we don't go as far as actually confirming. We call it probable, and then we go from there and manage it accordingly. That's very cool. We just don't have that many really super effective treatments that will park that. And then nociplastic is the group of pains that cause us most trouble because people think that when we say nociplastic, we think it's psychologically caused. I'm going to say from the outset, no, put that to one side. So nociplastic in the IASP definition, there's a change in the function, how the nervous system is processing information. So it's upregulated. it's not just the nervous system, because there's a whole bunch of other things in there as well. Neuroinflammatory, endocrine, that affects our processing. But essentially, I live with fibromyalgia, and for my fibromyalgia, I respond more to temperature. So my coffee is lukewarm to everybody else, but tastes hot to me. And I respond more to mechanical stimulation. So carrying a bucket handle, my hands, I will probably say ouch a lot more quickly than other people. There's a whole bunch of reasons why. Descending inhibition's not so great. My opioid receptors are partially already occupied, so I need more opioid if I'm going to get anything from it. And there's some changes in the way that the cortex processes all of this stuff. What we can't say for fibromyalgia is why. How come some people develop and how come some people don't? We do know there's probably some genetic stuff going along there, and there's probably some predisposition, and there's probably some events that trigger this off, like a virus or adverse childhood experiences. So nociplastic pains include things like fibromyalgia, migraine, irritable bowel, and lots of pelvic pain problems. Frozen shoulder probably falls into that group. Lots of non-specific low back pain falls into that group. So it's a vast group of pains not well defined. Well, they are defined because there's a change in the way that the nervous system is processing stuff. It's not inflammatory and it's not an identifiable lesion or disease. So it's not really by exclusion, but if we exclude those other two groups, then it fits into that bunch.
That was an excellent explanation with a lot of really good real life examples, which make it really easy to follow. Our next question was to talk about this influence on the nervous system. The other term that some listeners might be familiar with is neuroplasticity.
So neuroplasticity, quite simply, is that our nervous system responds and changes and adapts over time. It carries on doing that until we die. So anything can change the way your nervous system responds to stimulation, whether that's sight or sound, touch, or these things that result in our experience of pain. What we can't really tell is which came first, the experience of pain long term and some changes to the way the nervous system is processing stuff, or is it that the nervous system is processing stuff differently and therefore we have pain? There are some studies showing that if we've got experiences of pain that last a long time, there are changes that occur in representation in the cortex and elsewhere. But because we have got small numbers, because functional MRI studies are expensive, and because we haven't always accounted for important co-variables like neurodiversity, sensory sensitivity, and so on, perhaps we don't have all the answers yet. So I'm not going to confidently state that the brain changes in response to pain because maybe the brain is producing the experience in the first place. Maybe there's a bit of back and forth. Probably there is. So all I can say is that when you are experiencing pain that's been going on for a long time, you're going to respond differently in the world. That means your opportunities for learning is how neuroplasticity works. It's a learning process. And probably the way you move and do things, because you're experiencing pain, will alter what's going on in the way your brain is making sense of it and responding to it. Whether it's chicken and egg or whether it's a bit more complicated than that, I think it's probably more on the complex end.
That is a very great way to put it. And I think you're right. It is one of those things where trying to define chronic versus acute pain is not so simply put. And I think a lot of people don't understand that, or we haven't done a good job of educating on that, which is why I'm excited to share this episode with the general public, because I think there's so much to learn in terms of the nuance and the differences between the two. Building on that, you were talking about how pain influences everything and like how we interact with our world. So what is your experience with the psychosocial effects of chronic pain, and what have you been able to learn from that?
So all pain involves us making sense of what's going on. We usually think about that as words because that's the way humans work. But making sense isn't just words. It's also how we respond and move and plan and all of that messy stuff that we do as humans. So I think it's important to remember that Pain's defined as unpleasant sensory and emotional experience. So all pain, whether it's acute, inflammatory, or chronic, involves the whole person, biological, psychological, social. That means emotional feelings, judgments, beliefs, and how others respond to us are going to be present for everything from the beginning, probably even before. So that's good to remember. But I can tell you something, when you have a bout of pain, when it's acute, you're worried about what does it mean? Is it going to hang around? Have I done something awful? Or you may judge this pain as, it's a paper cut. I've had them before. They hurt, but it'll be okay. So we're always doing that. What's it like if you have a pain that you have never had before that hangs around? What sense are you going to make of that? As a person, as an everyday person, what does that mean? We learn about pain as kids. We fall over, we skin our knees and we hurt. That's how we grow up, knowing this is what pain is. And then along comes this weird pain that doesn't follow the rules. So how do you feel? Well, lots of people feel really threatened by this. Does this mean I'm going to be able to do what I thought life was going to be about? Why haven't they found out what's wrong and fixed it? Because, that's what we expect. Everything else works that way. How come I'm not sleeping? I don't know whether I can do the things that I really love because maybe somebody's told me I shouldn't because I might do some harm. All of those things add into what it is like to have this pain that hangs around, whether that's intermittent period pain or longer lasting neck pain that didn't go away, or a knee pain after an accident that just didn't get right, or a headache that comes and goes. All of those are going to have an effect because by definition, pain is this unpleasant sensory and emotional experience. It's just that as time goes on and it doesn't follow the rules, then we find it harder to make sense. And then the effects of not being able to do the things that you want to do, to be able to sleep, to get up and just move without having to think about it. Those things over time, that's going to have an impact, particularly if people doubt that you've even got it. Because how come? You did the treatment, it didn't work. Is it you that didn't do the right thing? Did you do your home exercise program? Because that'll fix things, right? People feel invalidated and judged, and they're worried. And from time to time, really angry. How come you're not taking me seriously? How come you haven't found the thing that's wrong with me? How come you haven't found the treatment that's working? That's horrible. And if we factor in some of the other things that we know affect whether somebody gets believed or not, like age, gender, ethnicity, educational level, ability to communicate in language, those things compound what it is like from acute pain onwards. But as you get further along, 2 years down the track, you've told your story 3, 4, 5, 6, 7, 8, 9 times, still haven't had somebody say, that sucks. I don't know what's going on, but I'm going to believe you. But instead, they've heard the scans show nothing to cause you pain. Look, you're absolutely fine. Everything's normal. I've done all these things. We're going to try this treatment, expecting a different result. You can see the effects that are going to have on that person. A life that's narrower and smaller and tinier and more constrained.
Yeah, just hearing you talk about that, it's very apparent to me that this is coming from personal experience because you understand it so deeply, and coming from someone who has also experienced going through the process of dealing with chronic pain and dealing with the different psychosocial effects of it. I can just tell how genuine and easy it is for you to talk about that because in part your research, in part you're working with patients as a psychologist, and in part your partner's pain. So thank you for sharing that. You actually mentioned something that really stood out to me where you were talking about how it can be very invalidating for patients to not feel like there's an answer to their pain or not feel like we can give them an answer and give them that solid cause of pain. And it can be very frustrating and validating for them to be told they need therapy or we need to target the brain because they don't understand that doesn't mean that their pain isn't real. It just means we're trying to change the target of what we're treating. How does one practitioner avoid this type of invalidation through the process of treating someone with chronic pain?
No, it's not something I have personally experienced clinically. And partly that's the group of people that I've tended to work with who have had pain for a long time. But it's also partly about the approach that I take. When we start with what's it like to be living with your pain right now? What's the effect on you? What do you think is going on? How are you feeling in yourself? Because here are all the things that you've told me you can't do anymore. What effect does that have on you as a person? Tell me about the worries that you might have. Tell me about the plans and the disappointments and the frustrations. That's the way I start looking at pain's this really weird thing. We don't understand it terribly well. We just know that you're experiencing it and trying to make sense of it. So that's when we can start to say, maybe let's have a look at what it is like and what things help you feel better. And it could even be as simple as tell me the times when your pain's really bothering you and tell me the times when it's not bothering you as much. Often it's when people are doing fun things or they're distracted by something, they're really engrossed in something. People will tell you it feels worse when I haven't been sleeping. Well, I'm really worried when I'm quietly in the middle of the night mulling it over and there's nothing to distract me. So we don't even have to split it out. Let's just be real. Humans experience pain, and when humans experience something weird that doesn't make sense, of course they're going to feel upset. And we as fellow humans can validate that without stepping into, well, I think you need to have a psychologist or somebody work on your brain. I don't even have that conversation. Just talk about what's it like, how are you feeling, and what can we do that helps you feel more like yourself.
Yeah, that's very interesting. Even just thinking about how I can apply it as a physiotherapist, I think that, at least from my understanding of what you've been discussing, is that instead of trying to spell out X, Y, and Z of these are the different types of pain and this is probably what's going on for you, it's like instead of going down that route, there could also just be like, let's delve into you. Let's dive into what's your lived experience and let's just talk about that, find out what your triggers are, what makes it feel better. And through that interaction of talking with that person, A, you're collecting information on how much there might be some psychosocial involvement, and B, you're giving them the space and opportunity to open up about how they're feeling, which a lot of the time people just want to feel heard. When people are in chronic pain, they've been tirelessly attending multiple appointments, trying to figure it out. And at the end of the day, they just want to feel that you genuinely believe what they're telling you. And so it sounds like just creating that space for them to do that is the best place to start.
Yeah, let's believe people. It's a really nice paper in Journal of Orthopedic Sports Physiotherapy at the moment from Ben Darlow and Gilletta Belden about, can we just trust people? Can we just take people at face value? Because what would that do? If we don't question the validity of what somebody's experiencing, we just take it as that's what they're experiencing. We don't have to question it. We can just say, hey, that sucks. How can I come along beside you, honour the fact that this is really tough right now, and be your partner, collaborate with you to bring more life into your life?
I guess I have a follow-up question about that. Would you suggest taking the same approach if you were working with someone who had more of an acute presentation of pain versus the more chronic presentation of pain?
Yeah, so somebody's got a fracture and they're in traction and their opioids are probably not lovely and they're feeling a bit nauseous and a bit horrible. And there's been a big event in their life. They've landed up in traction in hospital, big trauma. What's that like? One of the things we know is that people don't sleep very well because they're worrying. They're worried about what's going on. They're trying to make sense of it. So, of course, we can ask them, hey, you landed up in hospital. How are you feeling in yourself right now? What's that like for you? How are you managing to calm yourself down and feel like there's some certainty in your world? Because distress and responding to events is normal. Everyday people experience something that is out of the ordinary for them. It's not psychopathology. Psychopathology might develop. But just being a human, when life's turned upside down, means that we have these responses. That's normal emotion. And I'd like to normalise that for anybody. It's just when that hangs around for a long time, people start to feel demoralized and think, oh, it's not going to change. When they keep worrying and when they don't get an opportunity or they feel too scared to start experimenting with movements, then we have trouble. That's probably more important. And it's not so much that pain hangs around, it's that pain gets in the way or people aren't doing stuff. And this is where physiotherapy, occupational therapy really has a role to play, because our job is helping people do stuff. So let's know that we've got people who want to do stuff, can't right now for lots of reasons. Let's help them do stuff, and let's just scaffold how much we're asking people to do, knowing they're probably stressed out in acute pain. And in chronic pain, we just have a lot more time and a lot more mystery and scary stuff going on to make it harder.
Yeah, that was very well said. Thank you so much for sharing that. I think we'd like to talk a lot more about some of your specializations in the management strategies for unique presentations of chronic pain. You have lots of research on rebuilding self-coherence, restoring sense of agency. I think there's a lot of people listening that might not understand exactly what that means. Do you think you'd be able to just dive into really briefly, like, what does it mean to reoccupy yourself or regain your self-coherence?
So think about pain. One of the first things that happens when we have pain is that we stop doing the things and we try to make sense of it. That's why people go on Google and they see a health professional, because they want a label for it and they want to make some sense of what's going on. Everybody does that. And we make sense in lots of different ways. Some of it's what we acquire from Auntie Mabel, who had her back pain for a long time. Some of it's stuff that we make sense because we've had our own experiences in the past. And we think, oh, that's a bit like that, or that's really different from that. Some of it's from what Dr. Google will tell us, which could be of variable quality, shall we say. Some of it will be gossiping to the next door neighbour or whoever we've talked to at work. And some of it will come from clinicians. Hopefully clinicians are giving helpful, positive information, but not always. Sometimes we don't do a good job. Making sense is the very first step. Why? Because making sense means this is coherent with what I think should be going on, what I expect. So that's where this idea of coherence comes from, and we do it automatically. It's just that sometimes the things that we think are coherent actually aren't reality. So if it hurts and all your past experience has been when it hurts have done some damage, and now you've got a chronic back pain that's been hanging around for 2 years, then you probably haven't got damage. But it makes sense to think that it's like every other pain experience I've had. So that's an incoherent understanding. It isn't an accurate understanding, but it's coherent with this person's previous experience and everything they know about acute pain. It's just that this pain's not acute. So people are always going to make sense of what's going on. They make sense in lots of different ways. And what we can do as clinicians is help people pull together information from their own experience to help rethink about what does this pain really mean. Whether that's I've got ankylosing spondylitis, or it's a grumbly old non-specific low back pain, or I've actually sprained something. So having made sense of it, sort of got a sense of coherence, people then think about, well, what does that mean for me as a person? What I can do, what I like to do, my future, the things I wanted to do at home over the weekend, or my career, if I'm a nurse and I've got this back, and what about relationships with other people? What are they going to think when I can't do the things that I used to do? How am I going to be me again? In occupational therapy, we talk about occupations. These are the things that we do that are about who we are as people, how we express who we are. We arbitrarily divide them up into self-care, productivity, and fun, leisure. And so when we talk about reoccupying self, the way that we do those self-care, productivity, leisure kinds of things differs. The way that you do it and the way that I do it are going to be different. I clean my teeth, running around the house, making sure that all the windows are open. I've drawn the curtains, the doors, I've locked things up. Other people stand in front of the mirror, cleaning their teeth, standing in one place. Some people clean their teeth humming. Some people use an electric toothbrush. Some people do their balance exercises while they're cleaning their teeth. Some people do it 3 times a day. That's the difference between an activity and occupation. Occupational therapists, how we do that cleaning teeth, self-care thing matters. It's the routines and the habits and the things that we value about the way that we do it. So when pain gets in the way and we can't do the things the way that we used to, that changes how we're expressing who we are. That sucks. If you've got complex regional pain syndrome in your hand and hold your electric toothbrush in your right hand means that, oh my God, it really hurts, you have to change the way you do it. You have to stop, think, change hands, and you have to do it differently. Have you ever tried doing that? Clean your teeth with the wrong hand? It is really hard. Then it doesn't feel like you anymore. And if we pick on complex regional pain syndrome, it's a really difficult condition to live with, especially if it's in your upper limb. It's going to affect how you cut your food up, how you reach for a glass of water, how you do your clothes up, whether you can write, whether you can lie in bed with your hand out or underneath bedclothes. All of those are things that we do automatically until pain gets in the way and we have to start thinking about them. That's occupation. That's those bits that when we're looking at helping people reoccupy themselves, we want to look at how can we help them do those everyday things in ways that fit with who they see themselves as. That's what reoccupying self is about. And it means we're achieving the outcome, the value, the direction, expressing who we are, but we might use different ways of doing it. But as long as they fit with that person and their life and what they like and want and need, then that's probably going to help them feel more like themselves again.
I guess from your experience working with patients, have you ever found when people are in those beginning stages of rebuilding their self-coherence or restoring agency that they find it hard to try and build it based on the new version of themselves?
Absolutely. We often don't make a lot of room for grieving.
Yeah.
We don't always recognize that I may be able to do the things, but I have to do it differently so it doesn't fit and that doesn't feel like me anymore. So people can be angry. People can be really sad. People can be really scared. Who am I again? So pick a bloke. I like blokes. And he's a good dad. And what do dads do with their young kids? They love to play rough and tumble with their kids. They go to the sports, they wrestle, they throw them up in the air, they do all these physical things. And then this chap gets a back pain. And he can't do that anymore. What kind of a dad is he going to be?
Mm-hmm.
He's got this idea of this is what dads do. This is how I am a dad. This is getting in the way of that. So of course he's going to be scared, frustrated, angry, and probably a bit worried. I'm not going to be a good dad anymore. What does that mean? So we've got lots of processing to do when we have a pain and we're starting to think about what does this mean for me? And part of our job as pain therapists, regardless of our profession, when we start to help people do the things that matter in their life, is to help them find ways to be that good dad. It just might look a little different. And that means accounting for that sadness, that anger, that frustration. But it can also be positive and people can be curious and they might be able to explore other bits, how they are a good dad. We just maybe need to consider that to be integral to our rehabilitation and pain.
I'm assuming that you've probably come across patients in denial, right? Like not wanting to find those new avenues of being a dad or those new ways of moving about their life, right? I can imagine that's probably really challenging as well.
Yeah, I guess I'd use different words. I probably wouldn't say that they're in denial. I'd say they're really, really worried and puzzled and a bit stuck because this is how I thought I was going to be. This is how I thought life was going to be. It's not. How do I make sense of that? I really want to be the way that I used to be because that's what I expected. That's how I built my life. So that's normal, I think. Anybody who has some kind of pain or an injury or anything happen in life that pushes you away from what you thought was going to happen, is going to have some kind of impact on how you feel about yourself. And of course, you're going to push back for a long time because it's hard to say, oh, I can't do it that way anymore. Maybe that's for longer than I thought. People are usually okay to put things aside for a short period of time, a couple of months maybe, and then work back to it. But when it hangs on, that's when the grieving and those processes start. So that, I think, is just people want to try again and again and again to find the fix. And that's not a decision I can take away from anybody. What I can do is help them weigh up the good and the not so good about putting all your eggs in that basket of finding the fix. Meanwhile, your sleep's crap and your family life's sort of stopped and you're not sleeping very well and your work is on hold and life is on hold. That's the bit that we can do to help people work out how much effort they want to put into one approach versus opening up and looking at other approaches. If you like, it's based on motivational interviewing. Let's put stuff out there and lets you try it out and see the good and the not so good and the short and the long term of this strategy. And then as clinicians, back off, put the responsibility back to that person for them to make their minds up, because it's their life, it's not ours.
And that kind of answers the question that I was actually going to ask you next about how do you generate interest and motivation in patients treating the more mental domain of the pain when people are usually really focused on treating that physical component of the pain. But I think you worded it beautifully. You use a combination of the motivational interviewing and humanizing the experience for them and allowing them to come to those realizations that there are those other components at play and let them decide if that is something that they want to address or help give the right nudge in the right direction.
I don't even divide between mental health and physical and pain because it's always integrated. But pain always interferes. If somebody's asking for help with it, it's likely interfered with what they want to be able to do. So let's start with that. And when we ask about what it's getting in the way of, then we ask, well, why does that thing matter so much to you? Then we're tapping into values. Now, values are what drive motivation. Motivation is about my confidence that I can do it and the importance that I put on it. So if it's not important, I probably won't do it. And if I'm not confident, even if it's really important to me, I probably won't do it either. Part of our job is to identify the why, the values, that importance bit, and then build confidence by starting at a level that a person can manage and feels is achievable and start nudging towards the bigger and bigger and bigger goals.
No, I really like that you actually made the distinction that you don't make a distinction between the mental and physical because they're so interconnected. That was well said.
It's a whole person approach. If we think about ourselves as pain clinicians rather than I'm a physio who does this stuff and I'm an OT who does this stuff and I do a psychologist, when we look at it in a good, well-functioning pain team, we'll probably all do pretty much the same stuff. We might use some different languages and we might have a little bit more emphasis on some things than others, but underneath it all, we're thinking about this person whose experience is really weird and it's made up of these different facets that we can tweak, and really we're going to help that person start doing stuff so their experience will guide them as to how good that is for them, how much that's moving them towards what they really value in their life.
So once we take this whole person approach and combine all those domains and those professions, how can we, as PTs, as OTs, with that very specific knowledge, use this what and this why to inform our treatment plans?
Clinical reasoning. Awesome. So we know a lot of stuff, right? We know a lot about some neurobiology. We know a lot about building confidence. We know a lot about mechanisms. We probably know a little bit about some of the things that we know that influence pain. I like to start with the person and what they want to move towards, and then ask them, what do you think might be the next best steps to help you move that towards that value? So somebody wants to go back to playing rugby, and currently they've got a fracture and they're out of the cast, but their leg's just a wee bit wobbly still. It's a femur fracture. It's a bit sore, a bit uncomfortable. What do? We say, I want to go back to playing rugby. Where do we start? Well, what we can prescribe, but maybe we could ask the person, what are you doing at the moment that might be helping? What do you think needs to happen to help you move towards playing rugby again? Most people will have some ideas. It might be, well, at the moment, I can just walk around the house. Hey, what do you think? How far away are you in walking around the house to playing rugby? Oh, a long, long way. What do you think helps build your capacity? Oh, what have you done in the past? So we use what the person's already knows, the person does. We add in our specialised knowledge about healing, about fractures, about how we build muscle bulk and strength and resilience, so load and frequency, and we help that person work out something that is going to progress them. We add it to their already existing plans and knowledge. Now, some people will say, well, you're the physio, you should tell me. Hell, yeah, okay. That's fine. We'll start with, so here's some suggestions, but now we want to know, as PTs and OTs, how will you do that? So I've got this exercise program, but you've had this fracture, you're still at home because you're not back at work yet. I've got this exercise program, when are you going to do it? What's the best time of day? What equipment have you got? Can you travel in and out? How often are you going to do it? So we look at the things that might get in the way of being able to do this home exercise program, because we know people never do home exercise programs now, do they? Let's be honest. So we want to know what's going to get in the way of doing it. We want to make it as easy as possible for them to do it. And it's always tied in to their longer term, their direction, which is I want to go back playing rugby again. That's how we build self-efficacy, motivation, and we structure it using our knowledge about how much, what bits are about sort of physiological stuff. And we put those together to help this person come up with something that's going to work for them. All I'd say is don't assume that going to the gym is going to appeal to everybody, because it's probably not, won't for me. I've got a back pain and somebody suggests I go to the gym to get fit and help with my back pain, I'll probably slap you. I'll do other things. I dance, I fish, I kayak, I jump on the bike, I walk the dog, I do lots of things, but do not put me in a gym. Because there are lots of ways that we can build that capacity that doesn't look like some kind of prescribed algorithm, because that's not going to fit this person.
Truly patient-centered, empowering autonomy, promoting that independence.
Because agency is about this person making the choices, because they will make choices. They may not tell you that they've chosen not to do what you think. In fact, they probably won't, because nobody wants to say, well, I was a naughty girl and I didn't do that. They'll probably lie to your face. Oh, yes, I did those exercises. So if we assume that people probably won't do stuff if they don't value it, if it's not important to them, and if they don't feel confident, then we probably need to put more time into understanding what they will do, what they are ready for doing, and why, the motivations, the things that will help them do that. That's why we do it, because it's more efficient.
Absolutely. And what does that balance look like between setting realistic expectations that foster motivation, but avoiding false hope?
What's false hope? False hope might be saying, going to be fixed in 6 weeks. I can't predict that. Nobody can. But we can say, this is what we know from other people, their experiences, takes about this long. We don't know that that's going to be for you, but we do know that this gives you the best odds. the best chance. And if we have to vary that because age, access, confidence, other health conditions, because people don't turn up with just the one thing, then that's when we have those talks about the things that might affect recovery, which includes, like, I've got a busy life and this is not my priority. I've got other things I need to focus on.
Absolutely. Something else that I was hoping to get your insight on is people may have heard the concept of unlearning their pain. What can you tell us about what this means?
I think people believe that unlearning means that I'm going to reset my nervous system back to the way it was before this happened. We've talked about neuroplasticity and the fact that our nervous systems are constantly adapting. What we know is that once a pathway has been myelinated, it doesn't unmyelinate, it doesn't go away. What we do is we rewire beside it, or we go outside, or we kind of go around it. So that existing pathway lives there. So in many respects, I don't think we do unlearn pain. What we do is we learn there are different ways of doing stuff. The implications of that are, if we have a pain that's been there for a while and we manage to learn new ways of doing things, or we've rewired stuff so there are other pathways, under stress, whether that's I've got the flu, or I'm really, really tired, or I've had COVID, or I'm just depressed because life sucks right now, it's possible that those early pathways, myelinated pathways, are going to be much easier to activate than these alternative pathways that we've developed. I know I've had a particular location for back pain for most of my life. When I have had COVID, both times, that's where I hurt. That spot, I can put my finger on it every time. Same thing happens when I have the flu. So because that pathway is really, really well myelinated, it hasn't gone. I've just got alternative ways of my nervous system has wired. So maybe we don't unlearn, maybe we just add to our learning. And the more that we do the newer ways of moving and being, the more likely it is that those new pathways get more myelinated than the old ones. Think about riding a bike. You learn how to ride a bike in, I don't know, primary school. You don't ride a bike for 20 years. You can still jump on and ride that bike. We don't ever unlearn it. If you've had a spider phobia, I have a spider phobia, you will still have a startle response to an unexpected spider picture physiologically, even if you've had successful treatment and you don't avoid spiders anymore. It's still there. It's just that now I, as an ex-spider phobic, can go and be in the same room as a spider. That's the nature of learning. We don't unlearn stuff, we just embroider, add to it.
Beautiful example again, Bronnie, that made it nice and crystal clear. In that kind of same vein as looking to add to our system and our response, one of the things that you talk a lot about in your blog and in your research is acceptance and commitment therapy. So talking about learning how to live well and those strategies to do so, are you able to provide a little bit of an overview as to what acceptance and commitment therapy, or ACT, is and what all it encompasses?
Yeah, so ACT is about being flexible, but still moving towards the things that you really care about. There are many ways to get to or to live out doing the thing. It's back on, I don't know, being a parent. The way that I parented when my children were newborns is very different from the way that I parent today when they're 31 and 33. They don't have tantrums anymore, but I'm still a parent. So the way that I've had to learn to be a parent has changed. That's flexibility, that's psychological flexibility. I've had to adapt through, the terrible twos, and then starting school, and then when they hit the hormones at adolescence, and now they've left home, and now they're married and buying houses. The way that we do this is different over time. And so some people will want to stick with how they were as a parent when their kids were little, and they'll tell their kids what to do. Well, that goes down like a lead balloon when they're 33, right? Because kids are going to say, I'm a grown-up now, I'm not going to do that. And so if we get stuck responding and being the way that we were, and we don't flex and change and become responsive to the different requirements or the different ways that we can be a parent, we're going to run into trouble. We think about pain, most of us will think about what we do when we've sprained an ankle, and we will apply the same kind of strategies that worked when we first sprained an ankle to most of our pains. And then the pain comes along and it doesn't follow the rules. Back pain doesn't go away, but we're still thinking, it's like my sprain, so I've got to rest it up for a bit. I'm not going to go for the marathon. I'm going to do some exercise, but I'm just going to be very careful, and I'll probably limp a bit. If we get stuck doing that for a back pain that hangs around, it's probably not going to be great. So being stuck is when we're inflexible. And we all do that. This is normal. This is humans, because we've learned that worked. And we, better safe than sorry, we'll do it that way because it worked last time, so it should work this time, and then the situation doesn't. So in ACT, we say, hey, that's normal. That's being a human. Let's understand why. One of the reasons is that our minds are really good at words and sticky concepts, sticky understandings. That idea, if I've got a pain, it probably means that I've got some sprain or strain or some tissue stuff going on. That's a really sticky concept. It sits there in the mind, and the mind says, every time you have a pain, it means you've done this terrible damage to yourself, and if you do more, it's probably going to get worse. And our minds get really bossy. So our behaviour obeys what our mind tells us. Along with that, we don't really like feeling things that aren't very comfortable. We don't like feeling uncertain. So we do all we can to try and be certain, even if that flies in the face of our own experience. So if our ankle sprain responded to rest and then some exercise, and then we were a bit gentle and the pain went away, what we hope is that we'll do the same for the back pain, and we're not very willing to try something weird, like let's move even though you're still sore, because that didn't fit with what we did. So we're unwilling to do that. Makes sense. Perfectly understandable. It's just not moving us very far towards where we want to be. Then we have what matters. Sometimes the efforts that we go to solve the problem of pain get in the way of actually doing the things that really matter. So people spend lots of energy and time avoiding experiencing pain and doing all the treatments and not spending time with their family or playing or having fun or being with their mates, things that people really love in life. So that gets in the way of values-based action. The value in life is in living. So some of our problem-solving efforts actually get in the way because they're inflexible and they stick us into these rigid ways of being. And then lots of us get stuck with erratic or unhelpful actions. So you've probably met people who've overdone it or they underdo it. They're not going to follow the progressive way that we might use movement practices for people with pain. They say, nah, I'm tough. I'm going to do all the exercise all at once. And then they're going to be very, very disappointed because it didn't help. It just flared them up. Or they're going to say, well, you told me that I should be doing this, but I know better, or I think this is better, so I'm not going to do it. I'm going to do something else or nothing at all. So our actions might not always line up. That's partly because our minds are really bossy and we use previous experience even if it doesn't fit with what's really going on for us right now. There are two other bits. One's about us being humans, not being very present moment aware. So we remember things and we spend a lot of time remembering, the last time I did that, this disaster happened, so I better not do it. We anticipate, if I do this thing, it could hurt, so I better not do it. So we get stuck instead of noticing what is actually happening in the here and now. This is this present moment awareness. We can call it mindfulness, but that's got a whole lot of baggage. So I tend to say being present moment aware. Let's notice what's happening right in the moment. And then the bottom one is about our sense of self and who we're being. So we've talked about the good dad and what good dads think that good dads do. This is what a good dad does. Pain gets in the way and I'm not being a good dad. And if you ask me to do something different, that conflicts with my ideas about being a good dad. And that means I'm missing out on doing stuff because all the rules. So a lot of acceptance and commitment therapy is about helping flip the script, not through talking, because words are a bit powerful and not always helpful, but through doing. And we use values-based directions, things that people really love to do, things that will move them towards being the kind of person or living the kind of life that they really want. And we use present moment awareness, and we grade the actions, the committed actions, so they're doable and achievable. And we help people recognise that you might temporarily put aside your idea of what the good dad should do because you're in the middle of rehabilitation. So we're going to bracket that for a moment and let you be a person who's got pain, and we're going to do some rehab. And that means we can make exceptions for stuff. And often we move away from what the mind is telling us and lean into that uncertainty, lean into the being willing. Is it okay to have a bit more pain if we're going to start moving towards stuff that really matters? And people resonate really well with this. There's some training in it. It's not a thing to just read a book and do. And it takes a lot of thinking and reconceptualizing how you're working as a clinician, because it is a very different approach from CBT and physical therapy training programs where we coach or we tell people this is what you've got to do. It's much more fluid.
It sounds like it does take an intentional effort and focus to try and actively participate and get the best benefit from it. My question to you would be, if someone wanted to start acceptance and commitment therapy today, what would be your top recommendations on the best way to start?
I would start with something really accessible, and Russ Harris is probably one of the go-tos. Russ Harris is Act Made Simple, and he has a book, he has a website. Russ is a doctor in Australia, and he talks a lot about different ways that we can use ACT. For physical therapists, Joe Tatter's written a really nice book. I was looking for it. I've been using it. So Joe Tatter has a really nice book that is about using acceptance and commitment therapy as a physiotherapist. It's lovely. There's quite a lot of research showing that physiotherapists, occupational therapists, non-psychologists, we've got a sneaky way in because we start with doing and then we add in values-based action. We don't have to do the I'm going to tell you what to think. We don't go there because ACT says we're going to bypass that preachy mind. We're going to put it to one side. Let you notice that your mind's having a go. Let's try some stuff out and see what happens, see how that lands. So I would recommend Joe's book or the ACT Made Simple by Russ Harris as two really nice starting points.
I might jot that down at the end so we can link them for everyone listening. That's great. Thank you so much.
In addition to using this ACT resource and this motivational interviewing approach, because of your unique background in both occupational therapy and in psychology, is there any advice you can give to us physio students on how we can use both of your hats knowledge when working with chronic pain patients?
So all pain management is a team sport, always. So that means you as a physio are not alone. You've always got the person, they're a part of the team, but there's always other clinicians around you. You don't have to be everything to everyone. What you do need, though, is this hat that says people experience pain. Pain is this whole person experience. It's always got these sensory, emotional, biological, social bits to it. How they actually assemble isn't probably as important as recognizing we're working with a person. That, I think, is your starting point. And that in meeting a person where they're at, validating that this is sucky, this is a horrible experience. Anybody who has pain will say it's not nice. Even people who are kinky say the pain itself is unpleasant. So that makes it perfectly sensible and understandable that it's weird and you're probably feeling a bit upset about the whole of life and universe. I can help be your cheerleader. I can stand beside you. We can work together. And I'll bring my resources. You bring your life to it and your knowledge of who you are and what you like and what you don't like. And together we'll help you start moving forward. And then when we strike snags, for example, this person's actually getting quite low in their mood, recognizing it, and not waiting, not thinking, oh, I shouldn't deal with that, but saying to that person, hey, it sucks right now. You sound like you're really struggling. What help would you like? Can I help hand you over to somebody else? Being that warm handover, if you are going to hand over to somebody else, so that you're not abandoning that person. But what I can say from lots of years of teaching in clinical practice is that very often people won't want to speak to the person that they're supposed to, so they'll talk to you. If they are seeing a psychologist, for example, probably won't talk to the psychologist so much. They will with you because you feel safe. You're doing stuff that's not immediately on their mood. So they'll probably tell you stuff. Let's think about reflecting, asking, being curious, and supporting positive health statements like, yeah, we're going to get through this. Yeah, it's tough right now. Validate. And it's understandable. So again, validate. And we know that it will change. I'm here for you. That is good clinical practice regardless of your background. And then when you think there's something, this person's getting more depressed or more worried, that's when you hand over. But don't abandon them. Be part of the solution.
That partnership, making sure that they feel that they're an equal contributor.
Absolutely. That empowers people. That gives that sense of confidence that you have, that they have capacity, they can adapt, they can make changes. That's really powerful for people who are often otherwise feeling quite disempowered, feeling like nothing I'm doing is making a difference. I'm not making progress. The little actions a person can do that says, hey, you are doing something, you're moving, you're making changes, and I have confidence that you can do that. I'm here with you. I'm your cheerleader. That's the kind of stuff that makes a big difference to people who are trying to handle this really horrible experience.
Very powerful. To summarize for the audience, this idea of a paradigm shift in the way that we think about chronic pain, what does that mean to you? And a final concluding tidbit.
A paradigm shift. I think we spend a lot of time arguing about little technicalities, like how do we define nociception? How do we decide which bits are psychological and which bits aren't? I think we could probably put that to one side and remember that we are meeting another human being in the middle of an experience that we've all had. Our experience will be different from this person's experience because we don't know what it's like to be them. And the paradigm shift is to know that we can meet people where they're at and help them make some changes, take some actions for themselves, and start to move towards the things that make their life better, whether their pain hangs around or it doesn't. Regardless, we want to help people start feeling like they're making progress and that they can do some stuff and be themselves again. And there are lots of ways to do that. I think that's the paradigm shift, rather than, oh, we're going to do biopsychosocial and we're going to do psychologically informed. No, let's just be humans who meet other humans in distress, and we can be that safe place and safe person for that person to be welcomed and comforted.
That was so beautifully said, Bronnie. Thank you so much for speaking on this topic and sharing your insights. It's very clear how knowledgeable you are and how much experience you have working with patients. Everything you're saying sounds so genuine, and I know that if I was a patient, I would be thrilled to be able to have you helping me along being my cheerleader. So thank you so much for joining us today and just helping us get a better understanding of how we as physiotherapists can approach treating patients that are in pain.
One parting shot. Every one of us, any one of us, could be experiencing pain. There is no them in us. We are in the soup together. That is both humbling, but also powerful for us. We remember, how would I be if I was stuck in this person's shoes? What would it be like for me? What would I like? And I would like someone to affirm my humanity, to say, I'm still a person, I'm still unique, I'm still valuable, and I'm going to be partnered.
Yes, totally.
Thank you so much for the opportunity to talk to you guys. I hope I've made some sense. I know that it's a complicated set of things to talk about. But in the end, I want to encourage us to feel like we're a community who are trying to figure stuff out. And I hope that's kind of come across, that none of us have a good answer. We're still trying to figure stuff out. It's a whole bunch of experiments that we're doing. Informed experiment.
I totally agree, and I'm very excited to take what you said and hopefully apply it as I move into my career. So thank you again for sharing all your insights, and we look forward to sharing this with everyone, and hopefully they can gain something from it as well.
Thank you for listening to this episode on the paradigm shift and thinking about chronic pain. If you want to read more on this topic, we've included some articles and links in the show notes. Paincast is a freely available resource for you to advance your knowledge about pain and physiotherapy. We will continue to provide you with top-notch, evidence-based, and practically oriented content.
To help more people know about this amazing resource, follow us, rate us, and share our content with your network. Follow us on Instagram at paincast.psd, where you'll find bite-sized knowledge in 1 to 2 minutes. You can also use the feedback form linked in the show notes to help us improve. Thank you again, and stay tuned for future episodes on pain and physiotherapy.